Did you get that list I gave you? 7 o'clock.
Yeah,
Sure.
that's it. Okay. I think I
Have a
hear
good
that.
day, Doc.
With radio, Gwen Azama-Edwards, retired city clerk, former city commissioner, city of Daytona Beach. The Truth with Gwen Azama-Edwards on Goliath Radio.
Stan, you've been sitting much too long, much too long. Welcome, 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 welcome to Truth, a radio program designed with you in mind, a program whose sole purpose is to empower you, our listeners, for information leads to knowledge, and knowledge is power. And as always, I want to empower you to take control of your life, those things that impact you, your family, and your community. As always, too, I want you to go to the website at www.gwen-truth.com so you can access all those powerful links that link you to your municipalities, your county agencies, state agencies, federal agencies, and advocacy groups. And go there too so you can take part in the query that we have going. And in that query, I'm asking you about Obamacare, that's the Patient Protection Affordable Care Act, whether or not you feel that it will help individuals who are in need of affordable quality care. Go in so you can chime in on that, you know, and let me know what you feel. All right, you can feel free to put in whatever you want, however you want to respond, yes or no. Who am I? I'm Gwen Azama-Edwards, former city commissioner, retired city clerk, city of Daytona Beach, author, minister, St. John Missionary Baptist Church Incorporated, gotta say that plug for my hubby, and community volunteer. Want to do a shout out to all of our veterans, since Veterans Day is coming up on Monday, November the 11th. And shout out to all of our veterans living and dead, and to the family members of those who are both living and dead. They made the ultimate sacrifice for those who are no longer with us, and we just want you to know that we are so grateful. We're grateful as a nation, we're grateful as a people. And I really had several uncles who, and my dad, who are veterans. None of them are no longer around. None of them are around, but their memory lingers, as does the memory of all of the individuals whom we have loved and who've just done some great and awesome things for all of us. And again, to all of our veterans, we say thank you, thank you, thank you, and God bless you all. Shout out also to someone that I just love dearly. His name is James Hopper. We know that he is a writer for the Daytona Times. He also does a radio show for them. Got an email from him saying that his last day will be coming up in a couple of weeks in terms of his being a part of the Daytona Times family. So James, I want you to know how much I appreciate everything that you have done in this community to keep us all on our toes, to acquaint us with what's going on in the community. And you know, you may have found some, at times there were like some rough edges, you know, along the way when you share the information, but that's okay, because the important thing is that you let us all know what was going on, and if we didn't stand up and speak out about it, then that was on us. But you did your part by letting us know, and for that, I personally am just so appreciative, as I'm sure all of our listeners. So to James Hopper, current writer for Daytona Times, who will be leaving that position in less than 2 weeks, I just say thank you, thank you, thank you. Love you. And you just keep on keeping on, and much success in your next season and the next position that you will be taking on. All right? Okay. Tonight we have an individual who is a physician, and he's going to share some information concerning an issue that I've heard people talk about, and it has to do with dementia. And I've heard people talk about it. I've heard people who are, you know, around my age and younger, who are concerned about whether or not they may get it, if their parents had it, or whatever else. There's a lot of misinformation and a lack of information. And my guest is an individual who has not only studied, but he works in that area in terms of working with senior citizens, as well as being a professor who teaches younger physicians. Also, and fulfills a portion of what they're required to do, as he has shared with me, for our having a medical school in this area, and that is to have as a part of that gerontology being taught, or something as it relates to that. So his name is Dr. Neil Oslos. And he is, I'm just so happy and pleased to have you here with me. And, you know, like a lot of other people who are getting older, we get concerned about dementia, we get concerned about Alzheimer's, because we know that there is no cure, no known cure. We know that there are times when people might say, well, they know what causes it, but in actuality, maybe they do, maybe they don't. So share with us, if you would, a little bit about you, and you know, as it relates to what you're doing and working with some residents and the like, and then if you would explain dementia and what it actually is.
Okay.
Yes.
I work at Halifax Hospital. There's a family medicine residency program there. I'm a family doctor, but I specialize in geriatrics. And geriatrics was a field that, you know, wasn't even part of the training in family medicine when I started. In the early 1990s, people that were experienced in taking care of older people could actually take a test and become certified in geriatrics, and that's what I did. And then we became teachers of the people now. In order to be certified in geriatrics now, you actually have to do an extra year. So you do 3 years of a family medicine or an internal medicine, you know, residency, and then you spend another year to be certified in geriatrics. My position at Halifax, though, is I'm still primarily a family doctor. I work with a family medicine residency program. We have, you know, physicians that have graduated from medical school. We have 8 in each year, so we have 3 first years, 3 second years, and 3 third year, or 8 third year residents. And I work with them, and again, you know, I try to focus mostly on geriatrics, but I find I do, you know, a lot of general family medicine too. We don't have enough people that specialize in geriatrics, so we need to train people to do it, and that's what we're trying to do, and that's what Halifax has been trying to do with the residency program. Now, you also mentioned the medical school. Florida State has a medical school. They do the first 2 years in Tallahassee, and the last 2 years they do at regional campuses, and we have one of the regional campuses here. Florida State was one of the first medical schools in the country that actually mandated that the students had to take a geriatric rotation. So they take 4 weeks of their 4th year where they, you know, see older people and they sort of learn, you know, the care of older people. I think it's helpful. And these are students that are going to go into all different types of medicine, not just, you know, family medicine or internal medicine, but they're going to be surgeons, they're going to be cardiologists, you know, everything. So even, you know, people going into other specialties have to be familiar with, you know, some of the things that are a little bit more subtle in the care of an older person.
Oh, awesome. Now, in terms of dementia, what is it? And is it really and truly, as I heard a doctor say on Channel 13, kind of an umbrella name for memory loss types of illnesses?
Yeah, it is an umbrella term. I guess the thing I liken it to the most is, you know, recently, you know, we've heard the term, you know, heart attack, and then we've heard the term brain attack. You know, basically a heart attack is when the blood vessels to the heart, you know, are occluded and part of the heart muscle dies. That causes a heart attack. And a stroke, it's the blood vessels that go to the brain, and part of the brain dies, and that's a stroke. Now, in the heart, if enough heart muscle is lost, the heart can't function properly, so we tend to retain fluid, and we have what's called heart failure. In the brain, when we lose enough brain cells, and it can be from different causes, and that's why there's different types of dementia, but when we lose enough brain cells and the brain no longer can function normally, and we sort of have brain failure, and that's what dementia actually is.
And when we talk about Alzheimer's, which is probably one of the most well-known and probably misunderstood illnesses there is out there, that is then a form of dementia, and what actually happens to a person when that happens?
Alzheimer's is just a degeneration of the brain. You know, the brain, or the nerve cells in the brain basically die, and we don't know exactly what causes it, whether there's some inflammation there, whether it's, you know, somewhat hereditary. Lifestyle has a little bit of effect on it. I mean, so Alzheimer's is the most common type of dementia that we see. It can only be absolutely diagnosed if you actually do a biopsy, or you know, you do an autopsy. You have to actually see the brain cells, and you can see special types of abnormal cells that diagnose Alzheimer's disease. But we almost never do biopsies or, you know, things like that to diagnose it. There's enough clinical findings, changes in the person to sort of suggest that. But then we have other types of dementia. We have the next most common one is vascular dementia. If you have multiple strokes and you lose those brain cells through strokes, you also get dementia, and we call that vascular dementia. And then there's actually a mix, people that have Alzheimer's disease and they have strokes, so we call that mixed dementia, sort of mixed Alzheimer's and vascular. And then there's less common types of dementia. We have one that's called Lewy body dementia, which is one where there tends to be more hallucinations or delusions, and it's related to Parkinson's, but not necessarily all the features of Parkinson's disease. And then there's another type that's called Pick's disease, or frontal dementia, frontal temporal dementia. It's just an area of the brain that's affected, and that one causes more behavioral problems. So that one sometimes is hard to diagnose because their memory usually is fairly good initially, but they start having abnormal behavior. There'll be like the classic case is like a fellow that's a minister and never swore in his life, and all of a sudden starts using swear words. You know, so that's because of the area of the brain that's affected.
You know, I've often thought, and I'm sure other people do too, that when they see somebody and someone will say, oh, this person has Alzheimer's, and there's one that's, you know, has it and they're kind of docile, and they really don't say a lot. They sit there and mostly sit. And then there's the other who is cursing everybody out from, you know, one end to the other. It sounds like that is the one that you've just mentioned. And I've often thought, as do others, that was somebody who did a lot of cursing and use of profanity when they were younger. But that's not necessarily the case.
No, it's not necessarily the case. Sometimes it's just the opposite. And as I said, it's just the part of the brain, more the frontal part of the brain that controls our emotions and our behavior, just gets affected more severely. You know, the other thing is, even in Alzheimer's disease, so, you know, you can have behavioral problems, you know, because it's not like each one of these is a real specific disease. Again, it tends to occur because of some of the pathological changes that occur in the brain, but probably more so by the area of the brain that's affected.
And there's no telling what area of the brain that could be.
No.
Yes.
No, it tends to be variable. The classic Alzheimer's, though, is more of a global, affects pretty much all the brain. You know, the earliest signs usually that you know we pick up are when they start having memory problems, but there's other changes because the brain is immensely, you know, complex, and it does things that you know we can't even imagine, you know, how, you know, we put together a simple thought. And so the complex things that we do, you know, those are the things that are affected first, but those are hard for other people to notice, except for maybe close family members and things like that. And then one of the issues that we have nowadays is that medical care is so fragmented. You know, we don't have that many, you know, general doctors. There's definitely a need for significantly more. And the way insurance goes is, you know, a lot of times we have to switch from one doctor to another. So when I see a new person, you know, they might come in and they're a little bit confused or their memory's bad, and it's hard for me to say, well, that's how they've always been, or, you know, is that new? Whereas if I took care of them for, you know, 20 years, you know, I would see that change, and it would be a lot easier to pick up.
And that happened more, I can remember when I was younger, 60-some years ago. And there was a family doctor, and this was a doctor that everybody in the family saw, and he was the one who would send you here or send you there, but all the information would come back to this doctor who was the one that you would end up seeing, following up, and he would follow through on stuff and all this kind of stuff. But that's not necessarily the case, hasn't been for a long time. So to the extent you're able to follow up, but I guess, does electronic record keeping help with any of that? That record that's supposed to follow you?
You know, it should. It helps me in certain ways because, you know, a lot of times it's like a puzzle to get sort of put together. And if you have, you know, X-ray studies or lab studies or, you know, CT scans or MRIs that you can find, that can sometimes help you. They don't diagnose it, but if you can see those things, it can help you rule out other things. And the electronic health record does help us, you know, get that kind of information. The problem with the electronic health record, though, is the government mandates certain things that they want to measure. And so it's not necessarily the way a physician thinks. You know, it used to be we would write almost like a story, you know, like when the person came in, we'd take a history, and we would, you know, either dictate or write out what they told us. Now the way things are entered in an electronic health record, it's not always entered that way. It's
you gotta check off.
It's like a discrete data field, you know, and that doesn't tell you nearly as much. So it's harder in it's, you know, that way to figure out what's going on.
Yeah. Now, for elderly people or the baby boomers like myself who are starting to age and they have parents who have had Alzheimer's or they've had some form of dementia, and they're worried and concerned about this being something that they will get just based on the fact that their parents had it. You know, does it follow that way, or?
To a certain extent, but it's not nearly as much as most people think. And there's an exception. You know, people that have family members that have dementia at a young age, that's unusual, and that a lot of times is a stronger inherited trait. And even those people, probably only 30% of them, or they have about a 30% greater risk of getting Alzheimer's than somebody that doesn't have that. Somebody whose parents got you know, Alzheimer's disease, you know, in their 80s or 90s, their risk is not all that much greater. It's a little bit, but not all that much greater. It's almost, you know, some of the things we measure, it's more of a susceptibility. You know, there's certain things like heredity that make us susceptible to it, but we don't necessarily have to get it. You know, so if you have a susceptibility to it, and let's say you have a stroke that affects, you know, a fair amount of your brain that normally wouldn't cause, you know, you lose the ability to think, you know, or in an organized fashion. But because you've had the tendency towards, you know, a family that has Alzheimer's, you could, you know, have more severe effect from it.
And I would imagine that there are some things that would would increase your susceptibility to. I call it memory loss, you call it memory changes. And we were talking about some medication that actually can enhance issues and problems associated with memory changes, right?
Yeah, there's medicines, and that's a big problem, especially in geriatrics. But, you know, going back to the idea of dementia, you know, dementia is a permanent problem. You know, if you have dementia, you know, it's not going to change. It's not going to usually get better. It might get worse slowly, but it's not going to get better. And then there's a condition that's called delirium, or a lot of times we call it an altered mental status now. And that's more of an intoxication. It's a dysfunction of the brain from something, and that happens a lot with medications. And you know, some of even the over-the-counter medications can cause problems. One of the medicines that's problematic in that area is some of the antihistamine cold medicines that have Benadryl in it. There are also things that have their sleep medications that have Benadryl in it. Benadryl is what's called an anticholinergic, and it affects some of the chemistry in the brain that can cause confusion. So you can get a normal older person that will get confused and they'll get delirious from those medications. Not that common, usually they're sick or something else is going on, but it can happen. And then somebody that's got mild dementia or early changes, it's something we call mild cognitive impairment, and they take something like that, and then it makes them, you know, significantly worse. But that's transient. That will get better if you stop the medication. And one of the biggest problems as physicians that we face is we'll get these people that come in with these episodes of confusion, and the natural urge of a physician is to do something, to give them a medication, when really the best treatment is to stop the medications, but to do that, it takes days for it to go away, so it can be difficult.
Do antibiotics impact any of this as well, or?
Antibiotics probably aren't as bad. Most antibiotics don't cause problems with confusion, although, you know, any medication can interact with another one, and it might make the other one go at a higher level. So from that standpoint, it could be bad. You know, some of the anti-inflammatory medicines, the pain medicines, you have to be a little bit careful of. You know, some of the anti-inflammatory medicines in an older person can cause harm to the kidneys. It's not that you shouldn't take them at all, but, you know, they're not medicines to be taken every day usually. And the ones that are, the problem ones are things like ibuprofen, which is Advil, or Aleve, which is naproxen. Those can have some bad side effects. But usually not as much on the brain.
But it's important, as you were saying, that if you have to take these, to not make it an extended, extensive use of it, or extended.
As I said, the biggest one we have trouble with are the Benadryl-containing drugs, because older people have disturbances in their sleep, so they'll see something that's over the counter, they assume it's safe, and then they take it, and they can have some problems with it. So.
Because we're talking about older people, I've been told this, and I'm sure it's the case, that one of the biggest issues that older people have is in terms of, you know, bowel movements and the like.
Right.
And the medications can actually impact that as well, right?
Right. And over-the-counter pain medicines, the anti-inflammatory medicines do impact that. Prescription pain medicines can do that. Lack of activity cause problems, lack of fiber in their diet, or if they take fiber in their diet, they don't take enough liquids like water, you know, juice and things like that. So it's sort of a combination of things that affect the bowel.
Now, you were saying to me in terms of Medicare that there are some things that are not covered, and you felt it was important to share and have a discussion about some of those issues.
Yeah, that's always been a big problem. Is Medicare has been a type of insurance that focuses on treating diseases, and they've gotten a little bit better. They have some preventative things that they pay for, but for custodial care, like if you can no longer care for yourself, they don't cover that. You know, like, you know, it's a common misconception that, okay, you know, my parent or my spouse, you know, now has dementia, has Alzheimer's or whatever, and you know, they're having difficulty, you know, walking. They can't control their bowels or their bladder. I can't take care of them anymore. I'm going to take them to the hospital so they can put them in a nursing home. The rules of the hospital, and the hospital suffers because of this, is in order to be in a nursing home and have Medicare cover a short period of time, they have to be in the hospital for 3 nights. Now, if the hospital admits this person that doesn't have any clear-cut medical problem, it's more of a social problem, then they're not going to get paid for it. So, and then if they keep them in for 3 nights and they go to the nursing home thinks they're going to get paid for it, well, Medicare will come back and say, well, this wasn't a medical issue, this was a social issue, so we're not going to pay you either.
Oh, wow.
And then in the best of circumstances, you can only get in the nursing home usually for like 3 weeks, a 21-day stay, and if you're improving, sometimes they'll keep you longer, and then it has to go back to the cost, you know, being paid by the family or whatever their estate was and things like that. Now, eventually, you know, once you've spent all your assets, then you'll change over to Medicaid. You know, Medicaid is the insurance for people that, you know, are at a poverty level. and that actually will cover nursing home care.
Mm-hmm.
But that's not always ideal. Like I've got a lot of older people that don't have any money. They qualify for Medicaid. They get in a nursing home, but really they don't need to be in a nursing home. They need to be like in an assisted living facility because they can still do some of the things that need to be done. They can still maybe walk, they can dress, they maybe just need help bathing or have their medication supervised. But Medicaid, it's very difficult to get them to cover the assisted living. So it's very confusing. And I think that's a frustration for a lot of general doctors, you know, who's spending a huge amount of time trying to educate people about these things, trying to get people in the right place, and it's difficult. And that, like I said, people read Medicare literature and they see that nursing homes are covered, but it only covers real narrow definition of things.
And we were talking about advanced directive types of stuff where you have someone who's appointed to actually has the power of attorney or whatever to take care of you. That's important.
Yeah.
While you're still in your right mind, so to speak.
Right. In the state of Florida, in most states, when somebody turns, the age of consent, it's either 18 or 21, but once they reach that age, the state assumes that you're competent, that you have, full capacity to make all your decisions. And the only way that right can be taken away at that point is the judge. It has to have a court hearing. So what happens is, somebody that's, is getting, problems with their memory, they can no longer make decisions. The only way that, let's say that they need to go to a nursing home, but their house or their car needs to be sold, and they don't have anybody that's a power of attorney, that can't be done, The only way it can be done is you have to go to an attorney, you have to petition the court, for a guardianship hearing, you're evaluated by healthcare workers, and there's a significant cost. And that can all be avoided if early on, when there's, first start getting an inclination that there's a problem, or even if there's no problem, you talk with your attorney and you just have a simple power of attorney, a power of attorney for healthcare and a power of attorney for your finances. That power of attorney doesn't do anything unless you reach the point where you no longer have the capacity to care for yourself. And then, even at that point, two physicians have to document that you could no longer have the capacity, and then somebody else makes decisions for you.
So if someone were to go ahead and get that done, they don't have to worry about somebody coming in right away and starting directing how they spend their money or whatever else. It has to get to the point where they are no longer competent, so to speak.
Because if you wait to the point where they no longer can make a decision, then, as I said, who knows? That's why a judge has to decide at that point.
And at that point, as you said, it's really pretty expensive and costly for the person. We were talking about, of course, aging, and we're talking about a little about Medicare, but mostly about the memory changes that individuals go through, and the fact that people who are middle-aged think because their parents, had this happen to them, it's going to happen to them as well. But you had shared with me that someone because a lot of people think someone with Alzheimer's, the first thing that happens is they start getting forgetful. But you were saying that a lot of Alzheimer's patients don't say that they've forgotten.
Yeah, they don't realize.
They don't realize.
Yeah, the person that comes in and says, I'm getting more forgetful, I think I'm getting Alzheimer's. They're probably not, because usually the people that have Alzheimer's are brought in by their family, and as I said, I'll ask them, are you having memory problems? And they'll tell me no. And when they say no, the family just sort of glares at them. So that's not an absolute rule, but somebody that's is aware enough to know that maybe they're having a little bit of memory problems probably doesn't, have Alzheimer's disease. Our memory is, as we get older, our memory changes. And that memory is one of the things that we look at, when we diagnose Alzheimer's disease, but it's not the only thing. Normal aging, people are able to remember very well. In fact, the classic study done on memory in an older person was they took a group of college students and they took a group of older people and they had them memorize 10 telephone numbers. And the college students did it very quickly, and the older people took a long time. but when they actually were able to reproduce the numbers, the older people were actually more accurate. So we can, as we age, our memory is still intact, but it's just slower. It takes us longer. It doesn't imprint on our brain nearly as quickly as it does when we're young. Now, then there's early changes that you'll see. There's a condition that's called mild cognitive impairment. That's where the memory is probably worse than it should be. The typical test we'll use for that in office, a simple test, is usually just give them the name of 3 objects and ask them to remember it. Typically, the person who has mild cognitive impairment can't remember. They maybe remember one. Sometimes if you prompt them, they'll remember, but they don't. So they're having memory problems that are worse than what you'd expect, but they're still able to do what we call their activities of daily living. They're able to care for themselves. And then there's more advanced activities of daily living, like paying their bills, shopping, driving, things like that. So somebody that's having memory problems but still able to do that, we wouldn't consider that to be a dementia yet. Now, it's when they start losing the ability to do those complex things, when they, somebody was able to do their bills and their checkbook, and now they're having all these errors and they can't do it anymore. Or somebody that used to go wherever they wanted to, drive and didn't have any problems. Now they're getting lost. Those are signs that there's significant problem going in the brain. They're more complex things, but it takes a lot of brain activity to do those, and they've lost enough brain cells that they can no longer do that. So to really diagnose Alzheimer's disease, you have to have the memory impairment that's worse than what is expected. And then you have to have some of those abnormalities in your functional abilities.
And another thing I had mentioned to you, because I did not understand until someone mentioned maybe about 1.5 years, 2 years ago, why it is that a person with Alzheimer's dies. And even though they may die from that, you said what they will normally put on the autopsy or whatever, they'll say that there were complications associated with Alzheimer's. But what is it that's going on then that actually causes a person with Alzheimer's to eventually die?
The brain regulates our body, so as we lose the brain function, the brain regulation, things just slowly stop. People stop moving around, stop walking. When they lay in one position or sit in one position, their skin changes occur. They can get bed sores that make them susceptible to things. Their ability to walk gets worse, so they'll fall, they'll break their hips. And somebody that hasn't had any of those complications, that now they can no longer do anything, they just lay in bed, they have to be fed. Probably the last sign we see is when they start having difficulty swallowing. And then when they start having difficulty swallowing, either their nutritional status gets worse, or else they actually swallow, and when they do it, instead of going down the esophagus into the stomach, it goes into their lungs and they get pneumonia. That's always a tough place, because once somebody no longer has the ability to swallow their own secretions, their quality of life is really, there really isn't a quality of life. But it's horrible for family members, because they think, well, if I don't have a feeding tube put in them, or I don't have these heroic measures, then they're going to starve to death, or they're going to we're going to basically dehydrate them, and that gets hard. That when you see the whole picture, like I've seen people that have had those tubes put in, and you're basically feeding somebody that's no longer there. That they gain weight, but then they have other complications, and even doing your best, they're eventually going to die, because with those feeding tubes, they can still aspirate. So that's where I think hospice, comes in and does a very good service. They can, give people medications that, when you don't eat, it actually doesn't hurt you. It's actually a good thing, because you build up ketones, which make you unaware of things. That's why animals, when they get close to death, they go off and they don't eat. It just makes them less aware of the pain. But hospice, can give people like those medications to control their secretions. They can educate the families, let them know that they're it's terrible that they're dying, but they're not suffering. You can make sure that they don't suffer. So, but basically, the Alzheimer's causes death just by just a gradual breakdown of the body.
We were talking too about as you age, they're just things that happen, right?
Oh, yeah.
And I know, this is your area in terms of aging, and your eyesight. My husband likes to say your eyesight gets dimmer, and your steps get shorter, and you're this that. But that's all a part of the I guess what you call it, just the aging process. And yet there are some people who, in their 80s who are not as, active or whatever as they were when they were in their 20s or 30s, but they're still moving around, maybe a little bit slower, but they're still active, they're still able to do all kinds of things, and they're just as sharp as they can be in terms of their memory, in terms of how their mind works and the like. Is that all genetics, or is that them taking care of themselves, or just a whole combination of stuff that's probably gone on from, and some of these people actually, when they were younger, they drank, they smoked, they may still do a little drinking and smoking.
Yeah. Yeah.
Is it just the luck of the draw, or?
I think it's a combination. I think, the genes you inherit have a little bit to do with it, but the way you take care of yourself, your attitude actually has a lot to do with it. When we look at risk for Alzheimer's, the biggest risk is age, which we can't do anything about, but when you look at things that actually help maybe prevent Alzheimer's, one of the big things has been physical activity. Just somebody that stays physically active, somebody that stays socially active and stays intellectually active, those people have less tendency to develop Alzheimer's disease. Medications don't prevent Alzheimer's. Even there's drugs that we use when people have Alzheimer's disease, or they actually can be used for any of the dementias. But they're very limited as far as what they do, and that's something that sometimes is frustrating, because families come in and they think there's a medication that you can give somebody. They hear about medicines like Aricept and that are advertised, and this is for Alzheimer's disease. And when you look at the studies on those drugs, it's a complex thing to measure how the brain's functioning, but they use a 70-point scale, a 70-point scale. And when they put people on those medications, they improve 4 points on a 70-point scale. So it's pretty minimal. So, it's not that we don't use them, and I think some people it helps. The time I found this most helpful is when you get people that do have those behavioral problems. When they're starting to resist care, they won't let people dress them, or they get combative. Our choice of medicines at that point is somewhat limited. Tranquilizers can make confusion worse. There's medications that we use, to treat, schizophrenia or thought disorders. Things like the old drugs like Haldol, Thorazine. We don't use those, but there's medicines like that. But they've got an increased risk of strokes. So, sometimes using one of the medicines like, the Donepezil or the Aricept in a person like that, and it will help improve their behavior is helpful. The thing on those medicines, though, is they'll help for a while, and then, we have to know when they need to be stopped. When somebody no longer, is functional, then, it's not beneficial for them. It probably is not hurting them, but it costs, it costs the family, it costs, insurance, and it's probably not something we want to do. To do that, you have to sort of monitor people closely.
I'm going to say you're listening to Truth with Gwen Azama-Edwards. This is WLE 1380 AM on your radio dial in Ormond Beach, Florida, Goliath Radio. And my guest tonight is Dr. Neil Oslos. He is with family medicine. He's also a professor with our local regional medical center.
Yeah.
Yes, and with Halifax. And we're talking about, of course, dementia and memory changes for us as we get older. Younger people, especially the sons, the daughters of patients that you see who are getting older, who are not just getting older, but they're declining in terms of their health, in terms of their overall health, in terms of their memory in line with that. It's a difficult time. It's a difficult time for them to see their parents who used to help them as children. Now they're having to help their parents like children. It's like a reversal of roles in many ways. What do you say to them in terms of encouragement or whatever else when you have to deal with the children of the aging?
Well, you're first off, you're dealing with the older person that is having the problems, and I think the best thing is to let them make decisions, to sort of guide their treatment, to do things the way they want them done.
As long as they can.
Yeah, and sometimes that doesn't. It's probably not the best, and then if the children or the spouse or whatever can talk to them. A lot of times, if you repeatedly talk about something, and it'll dawn that maybe this is something I should do. Driving is a big issue with people with Alzheimer's disease. It's a lot of times, you'll have, especially here in Florida, we have, people that come down here that retire, their families are all over the country, so you have a husband and wife that are here. The husband's the one that's been driving, but now he's getting Alzheimer's disease. The wife is still pretty intact, and she can direct him how to go, and she doesn't let him drive alone. But when do you say that shouldn't be occurring? And that's hard. And actually, in Florida, as a physician, we don't have to report people that are impaired, for driving. We usually try to talk to families, and you try and do everything you can to prevent it. But there is a way, and if anybody is in that situation and they are aware of somebody that really shouldn't drive, that not only could hurt themselves but hurt somebody else, if you go to the Department of Motor Vehicles website in the state of Florida, there's actually a form that anybody can fill out. And what you do is you just fill out that you think this person they're impaired and shouldn't be driving, and what the DMV then does is sends them a letter, tells them their license is suspended, and then they have to go in for a test. They also contact the physician, and they want to they'll get our opinion whether somebody should be driving or not. But again, it's hard because a lot of times the transportation is really limited. So,
Yes.
So I always talk to people, and if they're in a situation like that, and they tell me that I only drive a short distance, I only drive in the daytime, I only drive it's not busy. Tells me they're at least thinking about it, and they're trying to be careful. And I'm a little bit more, I guess, I feel more comfortable when they're driving. Whereas if I get the person that tells me that I'm fine to drive anytime, and I drive out of 95, that's the one I usually tell one of the nurses to report them.
We had a neighbor who his son and daughter-in-law took him upstate with them, and he was 94, 95, still driving. I mean, he still loved to dance and all of this stuff. But he had gotten to the point where he was falling. He'd gotten to the point where he had difficulty eating and swallowing. So he had stopped eating as much as he had lost so much weight. And my husband actually called the son who was out of state and said, you need to come down here, you need to do something with your dad. We loved him dearly, but it was just time for them to get him. And they took him up, and he's in an assisted living facility now. Did not want to leave his home at all. And I think if this is a home that they've had, this is like familiar surroundings, a lot of them don't want to give up their home. And, the state is really trying to work with people to keep them in their home as long as possible. But even in terms of driving, it's like the last vestige of independence once you take the driver's license. And some, I'm sure, even once they're suspended, they'll still get in. If you don't take the car, they'll end up probably still getting in the car and going. older people, though, are some of the safest drivers on the street. I'm not talking really the older, but some of the older people are some of the safest drivers because they know they need to be extra careful, and they try to do that. But it is a difficult time as you get older and you're used to doing so much for yourself, and all of a sudden you just can't do it. You want to do it, but you just can't do it. And it's good that there are programs that are available in places that people can go and still maintain a nice, even assisted living, social life, make new friends, maybe even some current friends that you have are at the same place or whatever. There are opportunities out there, I think, for people who are getting older. Now, you were saying that you certify guardians.
Well,
Talk a little about the guardian.
as I said, the guardianship is a complex process. In order to have a guardian appointed for somebody, it has to go through the court system, and the court, actually the judge will ask 3 healthcare workers to evaluate someone. One person has to be a physician, but the other 2 are usually like a social worker or a nurse. And
I know my friend Elaine Holdown.
Yeah,
yes, she did it for years.
There's a lot of them. And basically we report, we write up the report, and the judge reviews it, and then there's a hearing, and he decides whether somebody has actually whether they're competent. The judge determines competency, and it's in the state of Florida they try to be as I guess as lenient as they can. So they sort of break down our rights into different things. Like, do we have the right to contract? Do we have the right to marry? Do we have the right to vote? Do we have the right to make decisions about where we live? And on this form that we fill out, we basically certify that they feel that they have the capacity, or they do have the capacity. And it's sometimes hard. I think we were talking earlier about voting.
Yeah, that's right.
That's one of the things on there. And years ago, I had this lady that they asked me to see, and she was pretty, she was pretty demented. I mean, she was still living by herself, but people had to come in there and watch her. But when and usually I'll try to go to their house where they're living so I can sort of see how things are. And her house was still neat, but she had aides there. But she was involved in politics. And, she had all her posters when she used to run for county council and stuff. And the attorney actually gave me a hard time because I pretty much said I didn't think she could do anything, but I thought she could still vote because she still thought about those things. And I mean, that's a judgment call. And as I said, the attorneys get a little bit upset when you tell them somebody can still vote, but they can't do anything about this. And that's rare, but that was the one person that I thought was different.
As we age, and we're all going to age, we're all going to die, what is it that you try to, as you teach the younger residents in gerontology and the like, what is it that that you try to convey? Because some I would think some parts of it it's difficult to convey, especially the hard part of it.
Yeah, I think the hardest part for young physicians is, you come into this field and you're all enthusiastic because you want to take care of people, you want to cure people, and the way you're taught to cure people is to give them medications. And the problem is a lot of times in older people, medications aren't always that helpful. Most of the studies on drugs are not necessarily, they might be done on people that are like 60 or 65, but they're not done on people that are 85. And they don't do the studies on somebody that's 85 and is on 6 other medications. So the hardest thing is to get them to think that, the best thing I can do for this person is to take away some of these medicines. Because then it's like you're not doing anything. It's like a negative thing, but you're actually helping them quite a bit.
Absolutely. Yeah, I know my mom, when she passed, she was on 20-some medications, and I don't even know how she kept it all straight and the like. That somehow we really have to get away from the increased use of the pharmaceuticals, even with our children,
Yeah.
and like, you know, to get to the point where there's much more natural healing and natural. My mother-in-law is big in that. Natural stuff that we do for ourselves and to ourselves that really can do more in terms of keeping us healthier and keeping us stronger as we age throughout the years. And do you find that there are some physicians or some residents who are actually getting into the nuances of what do they call that, like total, where you're actually using healthier and more natural and all of this kind of stuff? Do you do any of that in terms of training? Are they allowed to get into, you know, where you're doing more with how you eat and eating properly and doing exercise and doing, you know, a lot of the stuff other than, as you're saying, just taking medicine, you know, take your medication, go to bed, and tomorrow you get up and you feel a lot better.
Right. Yeah, no, they do focus a lot on that. I think, you know, a lot of the young people in general, you know, I think they're interested in healthy lifestyles, exercise, you know, staying active, and I think they try and encourage their patients. And, I mean, we've got, you know, I mean, doctors like anybody else. We've got some that are, you know, I mean, unbelievably good about it. You know, I mean, we've got a couple of the residents we have that, I mean, they just, you know, torment over it, that somebody's lifestyle, or, you know, they're smoking, you know, how can I get them to stop smoking? You know, it's the worst thing for them, or you know, just something they're eating so horribly, and you know, so they do look at that. But again, that, you know, people, you know, are so used to going to the doctor, and they feel like they didn't get anything if
They don't get some.
and so it's a natural tendency that, you know, well, gee, and so some of them have got so they actually will write their instructions on a prescription, and that sometimes helps. Although with the electronic health record now everything's electronic,
Right.
so you have to hunt around to even find the prescription. But no, I think that's the hardest thing. You know? And then the other thing is, you know, there's a natural tendency to, you know, when you take care of somebody that's older, it's, you know, they're getting sick, it's sort of like, you know, almost my failure, you know, I didn't keep them well. I remember years ago when I first started in practice, I rented a building from some guy that he was a physician in New York, and he'd always tell me that he was in practice for 10 years and none of his patients died. And it made me feel bad. I had people that were dying, you know, and as I said, so, you know, it's hard sometimes, you know, to look, you know, at that, but that's not really what you want to look at. You know, somebody that, you know, is having more problems is somebody that you can really help more. And, you know, I think as long as you realize your limits, you know, I can't do everything. I'm not God, you know, but I can make their life a little bit better. And so, you know, that's what we try and, you know, convey to some of the younger physicians. And you know, some of them like it, some of them don't. You know, it's like the medical students, you know, the ones that, you know, want to go into surgery are the ones that, you know, and I want to take care of this problem. You know, if I can cut it out, it's gone and it's taken care of. And it's just a different person, you know. We have people like that in all walks of life. We have people that are sort of the, you know, the real focused doers, and you got people that, you know, are maybe a little bit more patient.
Now, for any of our listening audience that are younger and considering a field of study, you and I were talking about the fact too that I read or saw something recently that said that our county, and there were 2 counties in the state that really had a critical need, severe need for physicians. And so we need more people going into the profession, and I know so many now are either going into a specialty, as you were saying, there aren't a lot of general practitioners, but they're going into a specialty where the money is, and you know, and a lot of them too are going into working with veterinary, you know, working with animals, because the animals now are getting the heart attacks and the need a kidney transplant and all that. I mean, people are putting a whole bunch of money into that area as well. So is there a need? Number one, I know the answer to that is yes, but I know the new that was probably a major reason for the hospital, the training, the medical training center here. Is there hope on the horizon for more physicians?
I think that, you know, there's been several medical schools, new medical schools that were built. period of time, it was almost 20 years when we hadn't had any new medical schools after the 1990s, and just in Florida, I think we've got 3 or 4 new ones that have come out. So I think that helps. The problem right now is that we're getting all these people that are graduating from medical school, but you can't practice medicine unless you do a residency. And residencies are funded through Medicare, through the federal government, and they have a freeze on those, so they're not making new residencies. So until they increase the number of residencies, we're going to have some difficulties. You know, it's hard to go into a primary care field when you come out of med school and you owe $150,000 to $300,000 in loans. When I went to medical school, I went to Indiana, and at that time it was the largest medical school in the country, but I only paid $1,100 a year. So,
wow.
So I got out of medical school for less than $5,000. So, for me to criticize people because they want to go into a field where they can pay a huge loan back, I can't do that. I had the luxury of being able to do whatever I wanted, and it didn't really matter from a financial standpoint. So, I hope, in the future the government will focus on these costs of these medical schools.
Right.
And if those can be subsidized somewhat, then maybe people can choose, a little bit, different, not necessarily because they want to go into a specialty. And there's nothing wrong. I mean, we do need specialists.
Yes, right.
Even like we're talking about dementia now, there's lots of, especially young people that get dementia, that's unusual, and they need to see a specialist. They don't need to see me. So, we need all types of doctors, but we just have to keep working on it.
Right. It would be great if there was that opportunity for doctors to be able to work off some of their medical costs by having to go and work in a poor area or something like they do for teachers.
Right.
To help deal with the costs that they've had associated with their training and the like. And in terms of the residency program, though, for those where you do have them, do they end up remaining in the area where they do their residency generally, or do they end up going back home to practice? Or you have a combination of things that happen?
It's a combination. Usually if there's opportunities in the area, they stay. Each year at least half of our residents usually stay. Most of the primary care doctors in our community have been from Halifax. And Halifax is one of the oldest family medicine residency programs, so that's been a good thing. The medical school, I think, has been a good thing because we need other, we haven't had any OBGYN doctors new to the community for a period of time. General surgeons, have been a problem, and now the medical school, has gotten students here that have seen the area, and maybe they've gone to another area to do a residency, but they're starting to come back. I think we're going to have at least 2 maybe that come back to do OBGYN here. Halifax actually started a general surgery residency, which I think has been very good. That's a hard field, because especially, the scheduled general surgery is good, but, we have general surgeons here that take care of trauma, and that could be any of us. It could be in an accident, and we go there and we need a general surgeon, and that's something that's not always paid for real well. And to have, a residency where, we're training physicians and get them used to this area and to keep them in this area, I think that's going to be real important too.
And we definitely need a lot of trauma doctors given racing and, bike weeks and all that kind of stuff that goes on. This has been great. Is there anything we have not? I know it's still a tip of the iceberg that we've covered, but anything else that you think we should share with our listeners?
I don't think so. I think, again, I think, just from a general standpoint, if people are interested in trying to do everything they can to prevent themselves from, having dementia, do some physical activity, do some walking, keep yourself active, your attitude. I guess that's one thing I should, we talk a little bit about preventable dementias. One of the things that we can sometimes see is what's called pseudodementia that occurs with depression. So, that actually can get better if the depression's, treated. So, keeping yourself active, keeping a good, attitude, being physically active, all these things can be helpful.
Wonderful. Well, I'm definitely going to do. I'm going to be. I've been a little lax about, going and exercising and all that good stuff, even though I try to walk every day, but to me that's not enough. I want to do more. So you have convinced me. I'm going to go out there and I'm going to walk more, I'm going to exercise more, I'm going to make sure I'm eating right and punish my husband and make him do the same. But we laugh and joke about it, but the truth is that we do have a lot of control, don't we, over the type of person we become as we age. And it's important for us to take control and to do those things that you've talked about, like the physical activity, the intellectual. There was another that you mentioned. Social, yes, social. As well, my mom, like I said, she was, she ran until the day she died, but she did puzzles daily. And they say that when you do that, you challenge your brain. That's the intellectual part of it that you're talking about. That's good. And it may be different for different people. I personally don't like puzzles. I may start to. Thank you so much. This has really been great. And as our listeners, if you're not familiar, I'm going to remind you again that I am recording this. I do upload it to YouTube so that you can listen into this conversation again and be reminded of the need to really and truly take care of yourself as you're aging. For those of you who are individuals who have parents who are aging and you're that person that's there for them, taking care of them and the like, it's important for you to be aware of this information as well. And as we were saying, to the extent that your parents, those that are aging around you, are able to do some things, let them do that. They will feel better, you will feel better. But those things where you see where they do have issues, do have problems, and they do want help, in that area, make sure that you help. And then in terms of the power of attorney, don't wait till things are so bad that it's, you got to go and spend a whole lot of money for, go to court to take care of that. And watch the medications and the like for yourself and for your aging parents as well. There's a lot that we can do. There's a lot that we should be doing, and it's real key that we take control. That's what it's about, taking control and doing the part of it that you can do. And we do have great physicians who are around to help. We have great facilities that are out there that will help us as well. And eventually, we do age and we get to the point where we're not as independent as we are used to being or want to be. And then there are those who are there to help us with that as well. This has been great. It really has. I don't know about you guys, but it's definitely given me kind of a new lease on life in terms of what to do as I get older, go on Medicare next year, and all this good stuff. And because you're getting older, there's no reason to give up, right? Hey, what we have is, hopefully a much better perspective on life. We understand, we don't get so upset about all kinds of stuff. We know that eventually, my mom used to say what goes around, what comes around, or whatever type thing, and that eventually things kind of work themselves out. Do what you can, and that you can't do much with, just pray over it and keep going. Oh, this has been great. Hey guys, remember to join us every Thursday starting at 6:15 or whenever I boot the big guy out of the chair, as we discuss issues to inform and empower y'all listeners. Also, be sure to go to the website, www.gwen-truth.com, so you can access all those important links to the resources and the information that will make you all powerful. Also, you go there and you can link on as well to the YouTube for this show and prior shows as well. And until next time, hey guys, be informed, be empowered, stand tall for that which is right and truthful. Again, this is Truth with Gwen Azama-Edwards and my guest, Dr. Neil Oslos. And we've had a great time talking to you about dementia and making sure that you're as fit mentally, physically, and the like as you can be. God bless. And hey, remember the veterans for Veterans Day, okay? God bless and have a great weekend.
WELE 1380 Radio, Ormond Beach, Florida.
Are you done now?
Now we are, yes.
It's Daytona Beach.